Okay, thanks for the introduction, Ali. So, as you said, I'm going to be telling you about our proposal to build a cloud-based resource for proarrhythmic risk prediction. And this is an area that my lab and Jamie's lab have worked quite extensively in from a research point of view. So this talk is really about harnessing that academic progress into something that's potentially commercially useful or of value to industry. The problem we're addressing here is one we're all familiar with, which is that of drug-induced arrhythmias, which really came to the fore in the 1990s when a range of drugs were withdrawn from the market because of their potential to cause sudden cardiac death. And it was identified that in most cases, this side effect was linked to block of the hERG potassium channel in the heart and the associated delay of repolarization and QT prolongation. And once that link had been established, there were guidelines implemented describing required assays for hERG block and repolarization delay. And those are summarized in the S7B and the E14 documents, where S7B in particular outlined requirements for preclinical screening. And last year, the first set of Q&A were published for S7B, covering things like integrated risk assessments and best practice for proarrhythmia models that I'll come back to later. So how have these guidelines impacted drug development? Well, as we know, there's now this growing concern that hERG activity is an overly sensitive predictor of risk that perhaps has prevented compounds that might have favorable clinical characteristics from being further developed. And it's easy to see why when we put some numbers around that. So there's an estimate that maybe 70% of compounds can block hERG at some concentration, and maybe 30% of new chemical entities have been abandoned solely on the hERG activity. And from a financial point of view, it's estimated to cost about $5 billion per annum for these tests. So it's quite a significant cost burden. And these factors, amongst others, motivated the FDA to propose CEPA, which aimed to quantify the actual risk of arrhythmia rather than having a sole focus on hERG activity in order to lower drug development costs, improve characterization of risk, and allow early and informed go or no-go decisions. And in that regard, we all know the CEPA working group laid out an exemplar pipeline from a high level that essentially consists of these three steps, which are high throughput screening against multiple ion channels, so not just hERG anymore, computer simulations and model optimization, and a risk prediction model. And this was all published in a series of papers, which I've referenced at the bottom here, which culminated in this white paper in 2020, which outlined those general principles for risk prediction models that form the basis of some of the S7B Q&A. But each of those stages of the new pipeline actually present quite significant challenges for pharma or contract research or academia. So for the data processing, we're now considering much larger data sets against multiple, so 7 different ion channels, again, not just hERG. The well-known complexity of protocols used to measure hERG binding kinetics and the quality control associated with those assays. From a simulation point of view, we're now talking about complex model parameterization, again associated with those models of drug binding kinetics, a requirement for uncertainty propagation, an extensive simulation. So you know, giving us this requirement for large-scale compute and the associated expertise. And finally, in terms of the risk stratification, there's the identification and calculation of new metrics, and also the site-specific qualification and validation of those for individual research sites. So lots of new hurdles in terms of expertise, capacity, and changing workflows. But this same set of circumstances we thought provide us with a window of opportunity. So to meet this need, we proposed this cloud-based service for assignment of proarrhythmic risk. that might facilitate SEPA compliance where necessary. And what do we see this looking like in a cloud workflow? So here's a schematic of a potential pipeline where we've got data streaming from automated patch clamp systems into our cloud platform. And we've been thinking about these tiers of analysis. So at level 1, you've got quality control and maybe simple assays like HERG hits or HERG dose response. At level 2, we're getting a bit more complex. So we're talking about analysis of multi-ion channel data, incorporating that into in silico models to predict repolarization effects. And then this comparison or ranking of test compounds relative to a reference library of drugs of known risk. And finally, level 3, where we might have a qualified risk model running in the cloud to assign specific risk labels. So that's the big picture. But as a first step, we've implemented the FDA's validated pipeline, which was based on this metric QNet as a proof of principle or a minimum viable product to try and demonstrate the cloud concept and test the value for different users in different sectors. So back to that pipeline and what we've done to facilitate and automate each stage. And the first step is in the data handling. Now, this might seem like sort of the more mundane end of the spectrum, but it's really critical in terms of getting good quality data through into the simulations. So this includes streaming of the data set, so the JSONs, the .dats from the SynchroPatch into the cloud, this fully hands-off advanced quality control and the data processing and analysis. And in particular, I think there's a method for robust and consistent quality control is really important. So I'm going to spend a few slides talking about that. To illustrate the problem, here's some data from GSK and from Astra that was summarized in the paper from Gary Miram's lab some years ago, which showing really quite significant variability up to an order of magnitude in IC50s here and here, and even more in the Hill coefficient from measures of potencies of a single drug against HERG at the same site on the same platform. Now, it's really important that we minimize these effects because the uncertainty in the measure of potency then propagates through to the calculation of risk metrics. So while I know there's a lot of factors that can contribute to this, I think one area we can reduce this variability in is by applying really robust quality control. So it's an area we've put quite a lot of effort into in terms of getting it right for our data processing workflow. So in our pipeline, quality controls handled at multiple levels. And in terms of what it looks like, first there's extraction of data and metadata from the raw file. So these are things like plate type, the voltage protocol, but also the current or cell type. And these are important because the downstream quality control are specific to different currents and different plate types. We've then got platform-based quality control, again, which is specific to the plate type. These are conventional parameters that we're used to seeing straight off the machine. And then current-based quality control. So for the sodium channel, we might use rise time. For some potassium channels, we use the morphology of the activation phase, things like current amplitude and stability. And then finally, getting onto pharmacology-based QC, where we're looking at goodness of fit of the Hill equation, whether there's an appropriate concentration range relative to the IC50, and whether we've included or how the negative controls behave. So the first of these is the platform-based QC. As I said, these are the measures straight off the machine that we're, any SynchroPatch user will be familiar with. Things like seal resistance, series resistance, and capacitance. And there's also some derivatives of these, such as delta seal. So how do things change over the course of the experiment? And what you can see here are the distributions of those parameters across a plate. And the red region highlights the range of values that we take through the quality control. And we typically lose maybe 20% of sweeps or 10% of wells on the plate, which I think is quite typical of a SynchroPatch run, as you'd expect for these conventional parameters. Then in terms of extracting data, here's an example of a herd current. I've visualized the average traces for control and drug, from which we generate these block profiles over successive sweeps for control, for the test drug, and for the maximal block. And you'll see in a few slides' time that we then use this experimental profile for more advanced quality control. A couple of other very similar examples just to illustrate some of those current or cell line based quality controls. So for KV 7.1, for example, we look at these amplitude ratios of the current onset to eliminate those currents that have non-sigmoidal activation, such as that one shown here, that might reflect a sort of inappropriate or irregular subunit stoichiometry in that particular cell. Similar for sodium channels, where we might filter on time to peak as a simple way of ruling out poorly clamped large currents that might confound the measure of block. And we've got similar current specific or cell line specific quality controls for most of our cell lines that we're analyzing. Excuse me. As I said, from those block profiles, we can also apply quality controls based on things like rundown, on stability, or on slow block. And we do this by using linear fits to individual portions of the experimental profile that you can see here illustrated with the dashed lines. And then we can exclude experiments based on the slope of these fits, maybe reflecting fast rundown or run up, et cetera, et cetera. And this is actually the stage that's probably responsible for most of the data attrition. And it's the one that coming back to that problem of variability in hill slope really tightens up that value across the plate. So what about some before and afters? Well, here are a couple of relatively extreme examples just to illustrate the point. We've got before QC on the left, post QC on the right. And you can see hopefully that we really do get an improved fit of the dose response curve. And we're able to maximize the data usage across the plate. And critically, we get improved confidence in the estimate of the IC50. So that's illustrated by this red box. And you can see that the width significantly decreases with the onset of quality control. And also improved estimate of the hill slope. So you can see highlighted in the box here, we're going from a very shallow hill slope pre-QC to something that's pretty reasonable after processing. In terms of the final product for the data, obviously this is a nice example, but we've got well-defined dose response curves. We've got tight 95% intervals on the IC50. We've got appropriate hill slopes. And we've also got tight confidence intervals on the dose response curve, so the green shaded area here. And this is important because there's reduced uncertainty in the measure of potency that's then propagated through to the calculation of the risk metric. So the next step is the model optimization and simulation. Now, these sort of simulations are pretty routine stuff in the field normally. What we do is we take the cell model, we alter the conductances of ion channels in that model based on a drug potency measured in vitro, and we simulate the effect on the action potential to derive a risk metric, which in the FDA case is QNet. But for this approach, there's quite a lot of added complexity, both from parameter fitting for the pharmacodynamic model and the propagation of uncertainty in measured block through to the calculated metric. So, for example, for every dose of every drug, so for the CEPA panel, that's 28 drugs, we've got to fit this pharmacodynamic model to 2,000 bootstrap samples. We've got to use Markov chain Monte Carlo to get IC50s and Hill coefficients for all the 7 currents for 2,000 samples. We then simulate action potentials for each drug thousands of times to equilibrate it at multiples of the Cmax in order to calculate the QNet and the risk metric. And what we found, there was a really large compute bottleneck for us associated in particular around the fitting of the pharmacodynamic model. And on top of that, there are very specific hardware, operating system and software library requirements that are necessary to really robustly produce the FDA data, which is also quite a challenge for the user. To get over that, as you guess, with our discussion of the cloud, we're using Microsoft Azure. So Azure is a cloud platform which allows applications and services to be developed, built, and deployed. There's large-scale data storage and critically, really massively scalable compute on demand. And importantly, for an application like this, where we're thinking about dealing with commercially sensitive data, there's the ability to securely permission and share data. And it also operates with hardware in 140 countries around the world, so we can preserve data residency that might be necessary to maintain compliance in the country of origin. Here's our implementation on Azure. We're using Azure Batch. Critically, again, we've used containers, so we've captured all the code, the operating system, the libraries, all packaged in a Docker image, so we don't have any of those problems with dependencies. We built an API using Azure Functions to deploy those containers onto Azure Batch. This is a scalable compute environment, and we're using Azure Share for storage. You can see here some of the outputs for just one particular drug. Now, these histograms at the bottom show the distributions of the 6 parameters recovered from fitting of this pharmacodynamic model to the 2000 bootstrap samples, and we're comparing Azure on the top to the FDA published parameters on the bottom, and you can see there's a very good matchup. These parameters are then fed into simulations, and what you can see here is the dose dependence of the distributions of QNet for 4 doses of Zimmelite here, just as an illustration. And critically, Azure really allowed us to smash that computational bottleneck. So we're talking about taking hours on Azure versus about a week per drug on our local machines. Obviously, that would depend on the resources available. And again, we've got very accurate reproduction of the published data all the way down to to the level of this kinetic parameters from the model. So finally, the risk metric. All I'm going to show here is just a summary of the calculated Torsade metric for our Azure pipeline for high, intermediate, and low risk drugs in the CEPA test panel, overlaid with the published FDA scores and errors. And you can see that there's very robust reproduction again. So we've got to the point now where we've got the full pipeline implemented in the cloud in Azure. And we're at the stage where we're looking for partners from pharma, CRO, industry to test, discuss, and develop further this process. Now, just before finishing up, I want to touch on one other aspect of that big picture schematic I showed you earlier in the talk, which is this concept of a gold standard reference data set, which we might use an alternative to explicit risk classification. So rather than implementing a risk prediction model to assign labels, what we're doing is developing the capacity to score or rank test compounds relative to a reference library of compounds of known risk. So what you can see here is an illustration of the concept using a new proarrhythmia score that we've recently developed in our lab, which you can read about in this preprint at the bottom here. And what we're doing is working on gathering the gold standard data against all these ion channels and using our data processing and quality control pipeline, processing this data so we can implement this ranking and scoring approach as part of as an option in our service. So just to summarize what I've told you, we've developed a cloud-based service for assignment of proarrhythmic risk. What we've demonstrated is data streaming from automated patch clamp platforms into a secure cloud. It uses hands-off, fully automated advanced quality control there's automated processing and analysis of the data. Model optimization and risk metric calculation are handled efficiently in the Azure cloud, and we've shown robust reproduction of that FDA validated approach. I've also discussed this concept of risk scoring relative to a gold standard reference data set as an alternative to explicit risk labels. And I just reiterate that point that we're very much looking for testing, development or beta partners, any feedback, positive or negative. And please feel free to contact either myself or Jamie on the addresses shown here. If you missed this, I'm sure someone from the NanoN team can put you in touch with us. So just to say thank you to the people involved at Victor Chang. Satya Arjunan is the lead developer, who is sort of ably assisted by Jessica Farr. Jamie is obviously a close collaborator of mine in this space. Dave Mihar is a cloud engineer who's been working with the Microsoft team to move all this onto Azure. Rob Love is a business development manager employed by Azure, who are some of the major funders of this work. Jeff MacArthur is a facility manager at the Victor Chang Innovation Center, who is gathering all the in vitro data for the reference data set. And finally, thank you to Microsoft Azure and to the team at NanoN for your support and for having us here today. So thanks, Ali.
Thanks a lot, Adam. That was a really great talk. It seems like a really useful tool for automated patch dump users studying safety pharmacology. I have a couple of questions here. Please, if anyone has any other questions, please put them in the chat or raise your hand if you'd like to join in with the discussion. Does the data, the submitted data, require some kind of specific open data format, like similar to that are submitted to the FDA?
Right now, no. We're using the raw .dat and the JSON files from the metadata from the SyncProPatch platform. I think in terms of broadening the utility of this, I know we probably don't want to talk about competitors here, but if, you know, equally the platform might be valuable for people using other platforms. So, you know, in the long run, an open data format would certainly facilitate that. Rather than, you know, making bespoke data ingress pipelines for lots of different data formats.
Yeah, okay. Of course, we have to admit there are other competitors out there that may want to use this tool. People
Not for
using
today.
So what is the data that gets fed in? Is it the raw data or is it already processed IC50 data?
No, just 100% raw data. Yeah, so so far we've done those 7 channels: HERG, 7.1 sodium channel, calcium, late sodium, 4.3 and Cur 2.1. So we're just taking in the raw data from those, and based on the metadata that's on the platform, you know, we're applying the relevant quality controls both for the plate and for the particular current type, and then processing those. You know, processing those data sets to derive our own IC50s post QC. A challenge, if we can talk about it, is making sure that sufficient metadata is entered, you know, by the SyncProPatch user. It certainly makes the hands-off approach much smoother, much easier if there's a very complete data set that's uploaded on the machine. So, you know, the old adage, you know, you can't account for people. We've always got to be sort of defensive in how we sort of build things to make sure there's you know, always an option for user input rather than just fully automated platforms.
You then have to sort of recommend certain experimental protocols, like incubation time. Obviously, things like that are quite important for you know, whether it reaches steady state and things. So you have sort of certain
100%, and the point that I made about you know, there's a lot more to the data variability than just quality control. there are things like the experimental protocol, the cell line, all those sort of things that are beyond our control. But what we can do is eliminate a lot of it, I think, with really robust and careful QC, and to whatever extent we can, we can recommend appropriate experimental protocols, and as I showed with those fits to the rundown slow block, we can at the very least flag those experiments where we don't have equilibration, or we can eliminate them completely. Because for sure, when we talk about that, really broad variability in Hill coefficients in data sets, we see a lot of that. So, slow compounds like dofetilide, those sort of things. If you're getting incomplete block, they're the things that really contribute to really shallow hill slopes. Similar for rundown, things like KB43, where you've got a lot of rundown at higher temperatures. That really contributes to the altered hill slopes. But we can eliminate all those with that advanced quality control. So we're trying to tackle it to the extent that we can.
Okay, great, wonderful talk. Thank you very much, Adam.
Thank you.